It's time for another warm-up review. Let's get going. Which types of proteins are responsible for fostering the progression through the cell cycle? So the answer is going to be the cyclins and also the cyclin-dependent kinases. Next question. Which cytokine is particularly important in maintaining granulomas? The answer here is going to be TNF-alpha. Next question. Which type of collagen is typically deficient in osteogenesis imperfecta type 1? It's going to be an abnormality of type 1 collagen. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to review the vascular supply to the brain and the functional organization of the brain, specifically the organization of the cerebral cortex. The cerebral cortex can be divided into the motor cortex and the sensory cortex, and the landmark that divides it is the central sulcus. All of the motor cortex is located anterior to the central sulcus, just like the motor of a car is located in the front of the car, usually. And then the sensory cortex is located posterior to the central sulcus. Let's look first at the motor cortex. Just anterior to the central sulcus is the primary motor area, and anterior to that is the premotor cortex, which may be involved in planning movement and guiding movement based on sensory input. Moving farther anterior into the frontal lobe, you get to the frontal eye fields, which is involved in eye movements, causing your eyes to scan over whatever it is you're paying attention to, kind of creating a visual map of that information. And then moving lateral along the frontal lobe, you have the motor area related to language production, which is called Broca's area. Now, if you know any Spanish, the Spanish word for mouth is la boca, which sounds like Broca. So Broca's area controls la boca. And in most people, Broca's area is located on the left hemisphere. Then posterior to the central sulcus are regions of the sensory cortex. So the primary sensory cortex is adjacent to the central sulcus and just kind of across the street from the primary motor cortex. And then as you move down that strip of cortex to the upper temporal lobe, kind of close to your ears, is the primary auditory cortex, which processes auditory information. Then just posterior to the auditory cortex is Wernicke's area, which is linked to the comprehension of language. So the primary auditory cortex processes the sounds you hear, and then Wernicke's area right next door is involved with helping you recognize those words and understand them. And again, Wernicke's area is usually located on the left. Then there's a bundle of fibers called the arcuate fasciculus that forms a connection between Wernicke's area and Broca's area to facilitate communication between these two areas, since both of these areas are involved with language. And actually the connections are bidirectional, even though this arrow just shows it going one way. And then the last area of sensory cortex I want to point out is the primary visual cortex, which is on the occipital lobe on the back of the brain, about as far from the eyes as you can get. Back up at the front of the brain, you have the frontal cortex, which I like to think of as the responsible, no-nonsense, business-like part of the brain. The frontal cortex is involved with judgment and decision-making, and also suppressing primitive urges. The frontal lobe is responsible for overriding the more primal animal urges like feeding and fighting and procreation that come from the more primitive parts of your brain. So a frontal cortex lesion can result in disinhibition and poor judgment and personality changes, and sometimes the return of primitive reflexes like the rooting reflex or the grasp reflex. We sometimes call these frontal release signs. Next, let's talk briefly about the homunculus. The word homunculus means little man in Latin, and it kind of describes the way the different parts of the body are mapped to different parts of the motor and sensory cortex. As you can see, both the motor and sensory cortex are laid out so that the head and face are located on the lateral part of the cortex, and then the hand and arm is superior to that, with the trunk and the legs kind of flopped over into the medial part of the cortex. And you can also see that the hand, for instance, maps to a much larger area of cortex than the feet do, because we need a lot of cortex to manage the fine motor skills related to our fingers. And the mouth and tongue map to a relatively huge area of motor cortex so that we can manipulate our mouths and speak. Now, clinically, the reason that these homunculi are so important is that occlusions of different cerebral arteries will predictably affect certain parts of the cortex and therefore affect certain parts of the body. So before we look at that, let's review the blood supply to the brain. Blood supply to the brain is very important for step one, especially the circle of Willis, which itself is about a 4 or 5 star topic. We're going to get to the circle of Willis in just a moment. But first, we have to get the blood from the heart and the chest up to the brain. So there are 4 arteries that supply the brain, 2 internal carotids and 2 vertebral arteries. Let's look at the carotids first. The common carotid runs up the neck toward the head inside the carotid sheath, along with the internal jugular vein and the vagus nerve. The common carotid then divides into the external carotid, which supplies the face and the scalp and the meninges, and the internal carotid, which supplies the brain. We're going to see the internal carotid contributing to the anterior part of the circle of Willis in just a moment. Then the vertebral arteries contribute to the posterior circulation of the brain. The vertebral artery arises from the subclavian artery, and it runs through the transverse foramina of the cervical vertebrae all the way up the neck. And then the vertebral arteries give off the pica, the posterior inferior cerebellar artery, and also the anterior spinal artery to supply the cervical spinal cord. And then the vertebrals merge to form the basilar artery. So the vertebrals and the basilar artery are the main blood supply to the cerebellum and the brainstem. So again, what supplies blood to the cerebellum and the brainstem? The vertebral arteries and the basilar artery. Now we're ready to look at the circle of Willis. You need to be able to label the circle of Willis either on a diagram or on an actual angiogram. So look at the diagram of the circle of Willis in your study guide and we'll label it together. I'm actually going to label these out of order, so just follow along with me. Starting at the top of the diagram, where the actual circle is, you have the main source of blood, which is the internal carotid artery, which is letter D. And then there are three main arteries that go out to the brain and supply blood to the cerebrum. Letter A is the anterior cerebral artery, or the ACA. Letter C is the middle cerebral artery, or the MCA, and letter F is the posterior cerebral artery, or PCA. And you'll notice that these three arteries are a little bit larger in diameter than a lot of the other arteries in the circle of Willis. So that makes these easier to identify. For example, you can see that letter F is a bit larger than letter G. So remember that the cerebrum is a big part of the brain, certainly bigger than the cerebellum, so the cerebral arteries are bigger than the cerebellar arteries when you have to identify them. In fact, the MCA, which is letter C, the MCA is just kind of a continuation of the internal carotid, so it really is a huge diameter artery. And as we'll see in a moment, the MCA territory of the cortex is enormous. Now, the reason that the circle of Willis is a circle is that you have these anastomoses between these three big arteries. And these anastomoses are called the communicating arteries. So letter B is the anterior communicating artery, which runs between the two anterior cerebral arteries. Then letter E is the posterior communicating artery, which connects the MCA to the PCA. So that does it for the anterior circulation. Now let's look at the posterior circulation of the brain, which supplies the cerebellum and the brainstem. In fact, let's follow the flow of blood up from the neck again. So letter J is the vertebral artery coming up from the cervical spine. And then the vertebral arteries are going to merge to form letter H, which is the basilar artery. And we said that the vertebrals and the basilar artery supply blood to the cerebellum and the brainstem. And then coming off the basilar arteries, you have a bunch of pontine branches, which aren't labeled here, but those pontine branches supply the pons. Now we said before the vertebrals merge, they give off two things. So letter L is the anterior spinal artery, and then letter K is the posterior inferior cerebellar artery, or the pica. So remember those two as the arteries that come off the vertebral arteries before the vertebrals merge to form the basilar artery. Again, it's the anterior spinal artery and the pica. Now look at letter I. If there's a posterior inferior cerebellar artery, it stands to reason there must be an anterior inferior cerebellar artery. So letter I is the AICA. And if there are inferior cerebellar arteries, that means there must be a superior cerebellar artery, and that's letter G. And again, the cerebellum is smaller than the cerebrum, so you can remember that the superior cerebellar artery is smaller in diameter than the posterior cerebral artery, if you happen to see them side by side and you're not sure which is which. So G is the superior cerebellar artery, and I is the anterior inferior cerebellar artery, and K is the posterior inferior cerebellar artery, or the pica. Now, it's one thing to label a nice, neat diagram, but let's also try to apply this to actual arteriograms. In real life, things tend to get squashed and distorted a bit, and real anatomy isn't perfectly symmetrical. And you can't identify every single artery on this image. But I hope you can recognize this circle at the top. And then what are these two parallel arteries very close together? Those are the anterior cerebral arteries, the ACAs. And what's the artery that links the two anterior cerebrals? It's the anterior communicating. And the anterior cerebrals run all the way back to here, which means that this is the MCA, the middle cerebral artery. And this great big fat artery is the internal carotid, which means that this, on the patient's left facing you, is the posterior communicating artery. And somewhere in here is the posterior cerebral artery, but they kind of get all jumbled up. But this big one over here on the patient's right must be the right posterior cerebral artery. And it's coming together with the left posterior cerebral artery to form the basilar artery, that big midline artery that runs down the anterior surface of the brainstem. Then the basilar artery splits into two vertebral arteries, and this little one coming off the top of the basilar artery is the superior cerebellar artery. And remember, the PCA is bigger around than the superior cerebellar. So that's a pretty good look at the anterior circulation. So now let's take a look at the posterior circulation. In this arteriogram, they've injected the left vertebral, and we're seeing some retrograde flow into the right vertebral as well. And then this is the basilar artery. And we can make out some small arteries coming off the basilar artery here and here. And then there's some arteries coming off the vertebrals here and here. So what do we say comes off the vertebral arteries? Well, there's the anterior spinal artery, which I don't really see, but it would come down like that. And that means that these coming off the vertebrals must be the pica. And these coming off the basilar artery are the AICA, the anterior inferior cerebellar artery. And you notice that these two kind of loop around the cerebellum and anastomose with one another. Then moving up to the other end of the basilar artery, we have a pair of small branches and a pair of larger branches. And one last time, the cerebellum is smaller than the cerebrum, so the small diameter branches are the superior cerebellar artery, and the larger diameter branches are the posterior cerebral artery. We don't really get good penetration of the contrast into the anterior circulation in this image, but you can imagine the posterior communicating arteries up here, and the MCAs, and the big anterior cerebral arteries coming up like this, and the little tiny anterior communicating artery. So that is the circle of Willis. Now let's talk about which parts of the cortex are supplied by each of those big three cerebral arteries, the ACA, the MCA, and the PCA. Now, this is another 4-star topic. You need to know what part of the cortex each of these three arteries supplies and what an occlusion of that artery is going to look like both clinically and what it's going to look like on a CT scan. Let's start with the ACA. So when the anterior cerebrals come off the MCA, they reflect backwards along the corpus callosum, supplying blood to the medial portions of the cortex down deep in the longitudinal fissure. And if you look back at your homunculus, you see that this corresponds to the leg and the foot region on both the motor cortex and the sensory cortex. So occlusion of the ACA will result in decreased sensation and decreased motor strength of the leg and foot area. Now, we said the middle cerebral artery is a big artery that supplies blood to a big area of the cortex, basically the entire lateral aspect of the primary motor cortex and the primary sensory cortex, and even Broca's area. So an MCA stroke is going to affect motor control and sensation of the face and the hand, and it may cause some aphasia. We're going to talk about aphasia a little bit more in a moment. And then the posterior cerebral artery supplies the occipital lobe. So a PCA stroke will be associated with visual defects because that's where the visual cortex is found. Now, we talked a tiny bit about Broca's area and Wernicke's area, which are both related to language. And we said that an MCA stroke could damage Broca's area and lead to aphasia. So let's talk about aphasia in a little more detail. Aphasia has to do with difficulties producing or understanding language. Some patients have expressive aphasia where they may understand everything that you say to them, but they cannot generate language to express themselves. And then other patients may have receptive aphasia where they may be able to speak, but they can't really understand what you're saying to them, or they can't understand what they read. So aphasia might not affect only speech, but written language as well. Some patients with expressive aphasia can't generate words to speak, and they also can't generate written words to express themselves. So think about aphasia as affecting language globally rather than merely speech. Now we typically think about Broca's area being related to language production. We think about Wernicke's area being related to language comprehension. So that's probably a little bit oversimplified because newer research suggests that Broca's area actually plays a role in language comprehension as well. But if you have a stroke or brain lesion that damages Broca's area, it typically causes a non-fluent aphasia or an expressive aphasia. We call this Broca's aphasia. So these patients may be able to say a few words, but they're not going to be able to string those words together into sentences. Now, their language comprehension is intact, These patients with Broca's aphasia have trouble expressing themselves. So I like to think about Broca's aphasia causing broken speech. Although again, it's not just speech, it may include written language as well. Now, Wernicke's aphasia occurs when there's a lesion to Wernicke's area, and that influences language comprehension. So in these patients with Wernicke's aphasia, comprehension is impaired. So this is a receptive aphasia. These patients have difficulty understanding what is said to them. And when they speak, they may be able to produce a nice fluid stream of words, but those words may not make a lot of sense. So we call this a fluent aphasia. These patients are going to string together several words into a sentence that just doesn't make any sense. There's also conduction aphasia, in which comprehension is intact and the language is fluent, but they can't really repeat what you say to them. So conductive aphasia occurs due to a lesion of that arcuate fasciculus, that tract that connects Broca's area to Wernicke's area. So if you say a phrase to the patient and you ask the patient to repeat it, there's no connection between what the patient hears and what he can express verbally. There's also global aphasia, in which both Wernicke's and Broca's areas are affected, and that means that these patients have impaired comprehension and non-fluent aphasia. There's also something similar to aphasia called dysprosody. Take a look in your study guide. Prosody means the musical qualities of speech, the rhythm, the stress, the intonation. Now, prosody can influence meaning, and it can be used to indicate emotion or emphasis. If I say, "You're going to rock step one," it carries a very different meaning than if I said, "You're going to rock step one." That's prosody. Now, dysprosody occurs when we lesion the cortex that corresponds to Broca's area or Wernicke's area, but on the non-dominant side of the brain. Remember, we said that Broca's area is located on the left hemisphere in most people because the left hemisphere is the dominant hemisphere. But if you lesion the same area on the right hemisphere, you get dysprosody. So expressive dysprosody is where you have the inability to express emotion or inflection in your speech. These patients come across as very monotone. They may seem depressed, like they have blunted affect. And again, this is due to a lesion of the non-dominant cortex that corresponds to Broca's area, so it's usually on the right hemisphere. And then receptive dysprosody is an inability to comprehend emotion or inflection or prosody in speech, which probably leads to a lot of unfortunate misunderstandings when they can't tell if someone's being sarcastic to them. And again, this is due to a non-dominant cortical lesion corresponding to Wernicke's area. Now let's review a couple of clinical syndromes that can result from lesions to specific parts of the parietal cortex. I'm going to start with Gerstmann syndrome, which is a 3 or 4 star topic. Gerstmann syndrome is caused by a lesion to the dominant angular gyrus, which is on the parietal lobe just posterior and superior to Wernicke's area. And like Wernicke's area, the angular gyrus is also involved with some complex language and communication functions. So a lesion here will result in agraphia, which is an inability to write, and also acalculia, which is an inability to do mathematical calculations, addition, subtraction, multiplication, that kind of thing. It can also result in right to left disorientation, so these patients can't tell right from left. And it can cause finger agnosia, which is an inability to distinguish the fingers from one another. So these patients can't look at a finger and identify it as a thumb or a middle finger or whatever. So they might get really offended if you gave them a big thumbs up. Think about it. So again, Gerstmann syndrome is a lesion to the dominant angular gyrus in the parietal lobe, which is usually the left parietal lobe, because most people are left dominant. But what about a lesion on the non-dominant parietal lobe? Again, that's usually the right parietal lobe. A lesion here can cause something called hemispatial neglect syndrome, which means that the patient neglects or ignores one side of the world, usually the contralateral side or the left side. So a patient may only put makeup on the right side of her face, or may only shave the right side of his face, or he may only eat food on the right side of his plate, or he may see his left arm and not really recognize it as his own arm. So now we're ready to pause the video and answer the end of session quiz. All right, first question. A lesion to which area of the brain is responsible for each of the following clinical scenarios? So hemispatial neglect syndrome is a lesion to the non-dominant parietal lobe, which is usually the right parietal lobe. Poor repetition is conduction aphasia due to a lesion of the arcuate fasciculus. Poor comprehension is a lesion to Wernicke's area. Poor verbal expression is a lesion to Broca's area. Personality changes and disinhibition is a lesion of the frontal lobe. And agraphia and acalculia is a lesion to the angular gyrus on the dominant parietal lobe, which is typically the left parietal lobe. Remember, this is called Gerstmann syndrome. Next, Which arteries are chiefly responsible for supplying blood to the brainstem? The basilar artery and the vertebral arteries. And the last question, what artery is damaged in each of the following presentations? In Broca or Wernicke aphasias, it's the middle cerebral artery. Unilateral lower extremity sensory and or motor loss is the anterior cerebral artery. And unilateral facial and arm sensory or motor loss is the middle cerebral artery again. All right, that's it for now. I'll see you next time.